All right, well, good afternoon again. We are getting all that we need from this engagement here in Alabama. I know I am, and really appreciate all of the effort and time and attention that many Alabamans have brought to PACHA and to our federal colleagues over the last couple of days. This part of the agenda will focus on hearing directly from you. How we typically do this part of the agenda is we actually will face you. I will ask my PACHA and federal colleague members along that back row if you can turn and face. Those of you who are along the sides, if you can at least face the room, and then this part of the room will come nearer to you. We are going to have lots of note taking because what is vital to us is that we do not miss any of the important information that we hear from you all today. So we capture everything on notes. And what we do with that is PACHA members and subcommittees, we actually take that back and we use that when we are planning and strategizing what do we do. I'm not sure about getting Medicaid expansion in Alabama will work for our PACHA agenda for 2020, but we are absolutely there with you and absolutely know and believe there's some vital things that we can do as a body. And so we do want to hear from you to take action. So we will have this next part of the meeting facilitated by, we wouldn't dare be in Alabama and not ask Ms. Dafina Ward to co-facilitate this engagement session. And we have our another rock star, Miss Alicia Diggs, who has kindly agreed to co-facilitate for her last meeting as a member. So I just want us to turn the floor over to you guys, and hopefully the community, the audience is geared up, both online, if there are some online, as well as those of you in the room to give it to us. So this is your time to shine. Go ahead, Dafina and Alicia.
All right, thank you so much, Chairwoman McNeese. Good afternoon, everybody. How you all feeling? How's the energy? Oh, this is good. Thank you all so much for joining us today. PACHA-to-the-People is all about hearing from you. And I do also just have to give a shout out to that last panel, who I think set the stage perfectly for this conversation. And we were touring the Legacy Museum yesterday. There's a quote going into the reflection room that said, "We stand on the shoulders of so many who have done so much more with so much less." It is true that you all are doing so much with little, and we know this. And so this is an opportunity to stand up and state strongly what it is that you need, the opportunities that PACHA can support, the work here in Alabama, across the South, and beyond for our friends who are online. So our first speaker, and we will invite you to raise your hand up because I know folks have some things you want to say. Y'all been sitting here quiet all day and yesterday. So we know folks have some things you want to say. But I want to start with Charlie Peterson and give you an opportunity to speak. And then we will go on and have folks speak from the audience. Here you go.
Thank you. Okay. I mean, that might not help. Yes. All right. So I actually was going to speak this morning, so I've got a little bit of a spiel, and then I do have a couple questions, so I'll be tacking them on to the end of my presentation. So good afternoon. My name is Charlie Peterson. I use he, el pronouns, and I'm the Director of Business Development and Community Engagement at Neelix Labs in Chicago. I serve on the board of directors at AIDS Foundation Chicago. AFC has 8,000 clients served through 40 Ryan White case management partners with viral suppression rates over 85% and 1,200 housing units, because housing is healthcare. With 23% of funds going to Black-led organizations. I'm on the Vernita Gray Council for Howard Brown Health, Howard Brown is the largest LGBTQ plus healthcare system and FQHC in the Midwest with 40,000+ clients and 9 clinics. I'm also the highest ranking non-governmental member of the Illinois Department of Public Health's Illinois HIV Integrated Planning Council, IHIPC. So we've mentioned many important issues and populations at this meeting, but I'd like to highlight 3 groups that I actually have personal ties to. People of Latin, Hispanic, and of Spanish origin, LHS, both recent immigrants needing language justice who are or underinsured and working hourly jobs, and established LHS individuals. 2, LGBTQ plus folks, but I'd like to use my gay visibility to highlight that individuals of trans and non-binary experience, TGNB, are overlooked in healthcare, with trans men and trans masculine folks being the least represented, also intersex. Thank you to our colleagues yesterday, Dory and others, who asked about initiatives and data tracking for individuals of trans expansive experience. 3, Indigenous people, often in rural healthcare deserts, facing high rates of syphilis and other treatable conditions after decades of healthcare underfunding. From discussions yesterday and the visit to Selma, people have seen what rural life can look like. I applaud yesterday's presenters for inclusive programs that are improving outcomes, health equity, and access to services, and for finding ways to circumvent conservative political jurisdictions. We must yet improve accessibility and syndemic approaches to health by 1, increased funding for clinicians with functional Spanish knowledge and the cultural finesse to navigate both recently immigrated and established LHS groups. Yesterday, we talked about the importance of words and of othering, and I can't think of a better example of this than people not being able to access healthcare because of inefficient language justice. 2, creating pathways for LHS, Indigenous, and TGNB individuals to enter healthcare and/or capacity building programs. 3, investing in decentralized testing and treatment approaches, including remote testing, point of care testing, more healthcare access points. We need that, right? So FQHCs, pharmacies, public health departments, local, state, community-based organizations, institutions of higher learning, departments of correction, and street medicine with mobile units. And 4, integrating care for HIV, STIs, behavioral health, and harm reduction, as these challenges overlap in underserved communities. So my questions: how can PACHA help push for more visibility, more representation, more program implementation to help these communities, especially since all 3 are disproportionately impacted by many healthcare conditions, with LHS being the only group with rising incidence of HIV and social inequities determinants of health? And also to really engage LHS individuals, because all our data and numbers is not representative of the LHS reality. If people are hiding from ICE and deportation, we're most likely not capturing them in our reports. Also, I'd love for us to acknowledge that we're on the lands first inhabited by the Creek, Cherokee, Choctaw, and Chickasaw. Visibility matters. Next question or answers?
Pause and see if from PACHA would like to offer any thoughts or reflections. Thank you so much, Charlie, for your comments and for your question. Are there any initial remarks or answers?
Can you restate the question?
Of course, Charlie, can you restate your question? Thank you. And we're also capturing.
All right. So how can PACHA help push for more visibility, more representation, more program implementation to help these communities? Let's see. And also really engage LHS individuals because the data is just not there.
Thank you so much. And that is a powerful and important question, Charlie. So we are capturing it because there might be a need for some reflection by members, if that's okay. Okay, would you like to ask your second question just to see?
Also, I understand because I can almost never answer a question without thinking about it. All right, second question. How can this council also commit to increasing accessibility to prevention, testing, and treatment? We've done some good work, but the political climate will probably dictate a lot of conversations with electeds and legislators for appropriations beyond and above level funding, pilot program ideation and implementation, and the creation of good old policy informing clinical protocols.
Any initial thoughts in response to any of the remarks that we've received from Charlie? Oh,
No problem. No, I'll respond and just remind everyone of PACHA's mission. And part of the work that we do is really inform and make recommendations to the federal response. And so you'll see, I think, tangibly a couple of examples just later this afternoon following this session with the work that we are set to vote on, potentially passing a couple of resolutions that speak a little bit to what you're describing, but just ongoing. We are committed to ensuring that evidence-based, science-based, community-led, community-voiced intervention is what is being supported through our federal sources. So I just wanted to make sure that everyone and you were clear about that is our core, that is our mission, that is what we're going to do. But I really do appreciate the charge and the challenge. I hear you loud and clear about what we need to do. Thank you.
I was gathering my thoughts on your first question. I'm Hansel Tooks. I'm a physician in Miami. I have to ask a clarifying question to you, Billy. In Alabama, are you treating undocumented folks for HIV? Okay. Because that was very heavy. I've
can you acknowledge?
Yeah, I'm acknowledging. So yes, so Billy is saying that people who are undocumented are eligible for Ryan White here, but even the questioning of it, I can see how it could be hostile territory for our brothers and sisters who have recently immigrated to the country. So yes, I'm sorry. I just had to clarify that point because that was very surprising to me. I come from Miami where we treat and love many undocumented folks. All of the doctors, we all speak Spanish and English. That would be my hope for everywhere.
We're expected to gather social security numbers from folks that that the way we document those things can be pretty destructive if we have to do a certain way. So that was really the point of my question, not that we can't serve those with Ryan White.
So what I will say is so the task of PACHA is to make recommendations to the secretary. Would you be interested? And I think that I'm very interested now in PACHA making a recommendation to HRSA HAB to have, guidelines that are uniform so that states aren't going beyond what is required to enroll in Ryan White. For instance, re-enrollment, re-eligibility every 6 months. I know there's the new guidance that you can do by year, but many states have remained doing 6-month enrollments. Do you think that would be something that you would like to see from PACHA? Yeah.
I do just want to remind us, we only have about 15 minutes and we want to make sure we have an opportunity to hear from more folks in the audience. And I know PACHA, you have brilliant things to contribute and we'll make sure that we follow up. This is a space where we want to hear from you. We can take this information and your input, process it and put it into action as we've seen happen in previous versions of PACHA-to-the-People. So I do not want to cut off my brilliant colleagues yet.
I was going to say, can you remind them that they still have until, I forget what the date is, to
December 19th.
to provide that public comment? And
Yes.
so what you're asking for can go in there and you can reach out to members from there.
Thank you, DeAndre. Thank you so much. But we want to provide an opportunity for additional remarks from the audience too.
And we also have community leaders online that would like to make comment as well. So since I have the mic, I will go on ahead. I think it would be fair to open up the lines for Jules Levin to make comment. And Jules, we appreciate you in advance, but also remember we are running short on time.
Okay, thank you very much. My name is Jules Levin. I'm the Executive Director of the National AIDS Treatment Advocacy Project, better known as NATAP. I've been living with HIV for about 40 years. I'm currently 75 years old, and I'm aging with HIV. NATAP is the largest organization in the world in terms of reach. Our website gets 3 million hits a month. Over 1,000 people register for our webinars, and we reach thousands and thousands of people globally and in the US. And I've addressed this body before about aging and HIV. This is a very serious problem. Currently, as of 2019, 50% of people over 50, but by 2030, we expect 75% of people to be over 50. Our HIV Ryan White healthcare system is broken. People who are older need more attention and more care. They have multiple comorbidities. I myself have 7 or 8 multiple comorbidities, and I have to see 7 or 8 different specialists, and it's impossible to manage all that. And the clinics, the Ryan White and HIV clinics, are completely unprepared for handling the situation now and in the future. When you go see a doctor, and this is my personal experience as well as many others, it's a 20-minute visit in and out. And the doctor is not educated and prepared to talk about comorbidities. And then the referral process for specialists, it's the very same thing. It's just a system that's not working. There is systemic aging, not just in the care system, but at HHS, and I would say the entire federal government. There's systemic ageism. Our problems are not being heard and addressed by this body adequately, nor at HHS and by the federal government. We've been talking about this for years, but the issue for us is this is existential. Many of us are 70 and 80 years old now, and without a better care system, people are going to be dying much more quickly, and they already are. People are getting early heart attacks. They're getting advanced kidney disease and dialysis sooner than people without HIV. So I'll just leave you with my question for the panel. What will PACHA do to help us change the bad care that older people are getting in Ryan White clinics? Thank you.
Hi, I'm all nervous, so I'm Jessie. I work at Unity Wellness Center. We serve 5 rural counties in East Alabama. My background for most of the time I've lived here has been in linkage, so that's kind of where this is coming from. And I handle all of our referrals, but particularly in rural areas, I do feel like we have a major underutilization of opt-out testing in ERs and urgent cares. And, we are still seeing disturbing number of people that are coming in who are not getting diagnosed after several ER visits. I'm currently working with our hospital to try to implement opt-out testing. It's easy enough. There are so many toolkits, there's so many resources, but I really do think if we're looking to end the epidemic and we're looking to really get people in care, we really need stronger recommendations from the government to incentivizing and getting these hospitals to opt out to implement. Oh, now I'm shaking. To implement opt-out testing. We just still have way too many people coming in sick and way too many people, not getting linked to resources sooner, and that is a tragedy.
Thank you.
Anyone else in the room would like to share, make a comment, reflection?
Hey, y'all, I know y'all got to hear a little from me when you came on the community engagement visit, but one policy that I just wanted to highlight that I think would really help us, especially in rural places recruiting physicians, is if Ryan White Part C clinics were auto-approved sites for the National Health Service Corps. So there are several types of clinics that are on the auto-approved list, and Ryan White clinics can apply, but is additional administrative burden. So I think that's one thing that could help.
Thank you. Can you tell us who you are, please?
Yes. Hey, y'all. I'm Landon Nichols. I'm the Chief Advocacy Officer for Five Horizons Health Services. Thank you.
Thank you so
I
much.
saw a hand over here.
Hello, everyone. My name is Myra Franks. I'm from Fayette, Alabama. I'm from Fayette, Alabama, a very, very rural area here in the state. And they've y'all pretty much covered everything that goes on, but I would like for you to amplify that in the rural communities where education is lacking, reaching the people. I not only deal with people living with HIV because it's only 15 according to the CDC in Fayette County. And because of HIPAA laws, I can't reach everybody, but the ones I do know, they don't want to talk to me a lot because I wear buttons. Yeah, because they don't want to. But I deal with people who are not living with HIV. And just like it was either TC or they said that they didn't know a trans, they've never met a trans person. In fact, they're telling me they've never met a person with HIV, which is unheard of in this day and age, Healthcare providers, the local healthcare provider, I did find one that would see me, but she had never met a person living with HIV, but she was willing to learn. She was willing to let me be the subject matter expert for my healthcare, and she interact with my infectious disease doctors. What else was I going to say? Y'all covered so much. Okay, peer-to-peer education is good. That would fall along the principles of meaningful involvement of people living with HIV. And because a person living with HIV can best understand another person who is going through HIV issues. A Black woman would understand a Black woman. A Black woman who is raising grandchildren living with HIV would understand, what all is going through. And that's a lot. Okay, so, and then so talking about peer-to-peer engagements, lowering the paper ceiling. There are many people living with HIV who have been in the field who do not have degrees that can do the work. And if they are paid accordingly, they could sustain their livelihood, they could get affordable, not affordable, but safe, sustainable housing. They would be able to care for themselves. So there are some insurance issues. I personally having found out that I had congestive heart failure as an older person living with HIV, I had 2 procedures in one day and my insurance would not pay for it. And I live in Fayette County, so the clinic was like 90 miles away. So I had to make 2 trips for that. These are just some of the issues. So as a Black woman of lived experience with almost 24 years, I was diagnosed 2001, January of 2001, who must address my mental wellness, and I must address my substance misuse disorder. I fit all of those intersections. Plus, I am aging. So I know I will have more comorbidities, just like the gentleman just said online, So make preparations for me and the other 50% of all people who are living with HIV. Get ready for us. And I do believe that we need more like groups in rural areas. I commend all of the work of the people who do the work in rural areas because I know that the work is hard. And as long as there are people living with HIV, the work is going to be here. Thank you.
I am Sierra Michelle Robinson, aka First Lady for Take Resource Center. I'm going to encourage each person in this room, including my group members, we cannot give up. We got to keep fighting, keep thriving, because God got more in store for us to keep doing. Because when God opens plenty doors, He got something in store for everybody else to keep doing the work. Because when the work is finished, God got more for us to do. We got to keep on thriving, keep pushing, have faith, and have more encouragement for our community. Because when your community is taught to do whatever it takes to have the courage to keep pushing, because the rising of the strongest is in us, to have the pride in ourselves to keep going. We forcing ourselves, we're gonna make it right. Doesn't matter what we go through in life, we still gotta keep going. No matter what you're going through, it doesn't matter how you got it, it doesn't matter how you get it. Long as God gave you the strength to do it, we gotta keep on going. Introduce yourself.
Good afternoon for those that have not met me before. I'm Larry Cowan. I'm the Executive Director of Selma Air. And I don't know how to go after that. I'm going with Solomon, but one of the things that I wanted to discuss is what was brought up for as far as MIPA, meaningful involvement of people with HIV and AIDS. I am one. Probably, maybe there may be one or two more, but I don't know. But I am the only one that I know of in the state of Alabama that is in a leadership position at an ASO. I don't like that. Because if we're going to have meaningful involvement, that means there need to be people at every ASO with lived experience at an administrative level, because they can tell you what is going on and what is right and what is wrong at your agency. I know that because I started from the bottom. I know it's all started from the bottom and now we're here, but this is not it. I started from the bottom and I've worked my way up. And I know there are many at all of these ASOs that can have their exact same involvement. So I want to charge you all and ask you all, what are you all going to do to push for these ASOs and CBOs to have client level involvement, not at just the bottom, but at the administrative level as well, because they can give you the information that you can't go out there and get.
Hello. Oh, is this on? Okay, yeah, I'm loud. It's not a question, it's a comment and a sense of deep gratitude to PACHA. Since CHOP has always had a long relationship with PACHA, and it's often one that has like a air of opposition to it in terms of the positions we take and the interest that we have. And I don't want to speak for anyone else, but I'm very, very worried and very, very nervous as far as what happens on and after the 20th of next year. And part of how I'm dealing with that as a leader is to remind myself and remind our staff and to remind each other that even if this body isn't in actualization, CHOP is still here as a partner in the work that each of us do as agencies and as individuals. I know mainly our involvement in PACHA has been around more consent and other concerns as it relates to MHS, and that's still going to be a focus area of ours. And I want to just offer many of our other resources. CHOP is probably most known for our resources and data around the criminalization of HIV. CHOP has just updated all of our maps. So hopefully it's a tool that folks can use and will use as we're having these sort of conversations. Now we have several maps that talk about various aspects, of this issue. Our staff attorneys have worked to update our timeline, and also our staff attorneys have actually worked to draft a model data policy that we're hopeful state and local health departments are able to use as we engage at the state and local level on data privacy. It was released on World AIDS Day. And so all of that to say, I'm hoping that the work that we have done so far and continue to do, that even if this is not the body that's able to do it, that us as individuals and agencies are still able to continue to work together. CHOP is here. We're not going anywhere. I know that's true of everyone in this room. So I'm just hoping that the work is able to continue, even if, you know, other factors aren't at play.
Thank you, Mandisa.
Just for HIV on policy for those who know. That's the Center for HIV on Policy. Thank you, Mandisa.
Hello, everyone. I'm Vontrice McGee, the Director of the Office of HIV Prevention and Care with the Alabama Department of Public Health. I would love for the federal government to rethink how we use the funding that we have. We have HRSA funding, CDC funding, and rebates. Our office receives very limited state fundings with restrictions to those. So how do we serve non-positive high-risk people that need housing, that need transportation, that need all those services that Part B provides, but you have to be positive. So even if it's just rethinking the allowable use of rebates, how can we help those organizations like the ones that spoke today to ensure people remain negative, but are at risk and are allowed, are able to receive those services?
One more state. My name is Lena Cherie Hinton, and I have a question for the agencies. How is it that the minorities of African American, why is it so hard for us to obtain life insurance until we have to reach 50 or 51 years of age?
Good question. That's a very good question.
I've been trying ever since I was in around about my 20s, mid-20s. And due to the underwrite, I had to wait until I turned 50.
Challenges of accessing life insurance. All right, thank you. We're capturing that for the record, okay? Is there anybody, you said agencies, does anyone want to attempt to respond or have an additional follow-up thought to that? Okay. Would you like to?
So I am Jerome Ellis. I work for Wiley Health Services. I am the prevention and retention coordinator there. And I have done insurance previously in my past careers. The reason why they see that a person who is living with HIV or with AIDS, they see you as being a higher risk. So they want to place you into as a category so they can make your premium higher. And as you're paying that higher premium, it's giving you a smaller gap to be into a more catastrophic group. So yeah.
But Dafina, can I just add for
yes, please.
To expand on the context, it is an industry that has not updated the facts about HIV. And so it is an industry that still believes that, day one, you have HIV, that you will transition day 30. I'm just using some numbers. And so it's this acceleration for people living with HIV. And I think that is a topic that PACHA could possibly address in the future. So thank you.
Thank you so much for that, Marvel. Let's see. I think we've reached time. We've reached our time limit. Thank you all so much for sharing and PACHA-to-the-People and for your support for our work moving forward. Thank you.